NDSU. So my name is Jeremy Jackson. I am the director for the Center for the Study of Public Choice and Private Enterprise. And we do have, of course, a snazzy mission statement as a center, advancing knowledge of the sources and causes of human well-being and the distinctive roles of entrepreneurship, free markets, philanthropy, private enterprise, and public policy in achieving it. It's kind of a lot of words, but we're basically about finding policies that can help make people's lives better off. And that's actually a big part of what our speaker today is going to talk about. So he fits right into our main themes of what we're trying to do as a center. We, as a center, of course, we have people like myself who produce lots of research. We're going to have more people coming on board to do research for the state to help us find policies to improve people's lives. But we also have activities like this one that are more centered on not necessarily academic work itself, but providing an opportunity for us to come and learn about something new. So there's actually a lot of opportunities that we're going to have actually to engage undergraduates, also in things like reading groups. So we have a lot of opportunities that are going to be coming up over the next year, and there's actually some scholarships that are going to be available for participation in some of these reading groups that we'll be running. You have a piece of paper that we handed out that's really designed to help us find out what is going good about the presentation that you're seeing today. But also you have an opportunity at the bottom of that comment sheet that if you would like to be on our email list so that you could find out about more events like this or reading groups, various things that we'll have going on. If you put your name on there, we'll put you on a mailing list so you can find out about some of those activities as they pop up. And I do want to give a plug, of course, because I have one more lecture that's going to happen this semester. I have Dr. Virgil Storr, who does a lot of work using, actually he's kind of interesting in the world of economics because he uses a lot of the techniques from sociology to study phenomena in economics. And he's done a lot of work looking at the entrepreneurial response to things like Hurricane Katrina. So looking at how we can help people after a natural disaster occurs, how can we help them get their lives back up and going? So he'll be presenting April 3rd, and this will be not on main campus, but actually in Berry Hall in the downtown campus. And that's going to be at 4:30 instead of 5:30. I also want to make note that another great way to keep up with what we're doing as a center is we have a presence on Facebook and Twitter. And if you like us on Facebook, of course, you would have an easy access to all of the things we have scheduled. So do, if you can do it right now. No, none of you brought your cell phones to this, right? But you can go on and actually like us on Facebook or follow us on Twitter. I won't care if you do that. But that's all I want to make of an introduction for the center. I'll introduce our speaker for the day. So we have Dr. Mitch Mitchell. He is the director of ACRE, which is the Arkansas Center for Research and Economics at the University of Central Arkansas. And he's a regulation economist, so he studies the impacts of regulations. And he's had works that have been published actually in a lot of mainstream publicly available publications like Forbes, USA Today, The Hill. He's actually written on some really, I would say, more lighthearted topics as well. So he's published a paper on labor markets in The Simpsons, and also another paper on trading with the undead. So with that, I'll turn it over to you.
Thanks.
I got to switch it.
Oh, okay. So yeah, my name is Mitch Mitchell. Although my parents didn't name me that, they're not creative, but they're not that uncreative. I want to talk a little bit about scope of practice. Oh, and I want to think, what can economics tell us about improving access to care, improving fairness, and having compassion? And of course, as an economist, I had to go to Adam Smith, the founder of sort of modern economics, and Milton Friedman, both people who talked about this issue not directly in terms of scope of practice, but in terms of occupational licensing, about how regulations can make the world less fair, reduce access to products and have less compassion. And I'm going to give you a little lead off just in case for some reason there's a fire alarm. I want you to know what happened in the world. So scope of practice is a barrier to entry, raises prices, reduces access to care. Broader authority for nurse practitioners, that's what I'm actually mostly interested in, is nurse practitioners. And leads to more nurse practitioners, that sounds good. And nurse practitioners provide very good primary care, a wide range of primary care issues, I should say issues, including diabetes. So hopefully you guys do not have type 2 diabetes, but it is a common issue for lots of people, and especially where I live in Arkansas. Arkansas, we like to be #1, and we are #1 in type 2 diabetes, hospitalizations for pneumonia, and sometimes we're able to beat Louisiana for obesity. So we got that going for us. Actually, Arkansas is a great state. I love it very much, but there's certain things like, man, I wish we could be #1 in something else. So first of all, you're like, I don't even know what scope of practice means. So scope of practice is the regulations that tell professionals which jobs they can and can't do. What are they allowed to do? Are they allowed to prescribe medicine? Are they allowed to prescribe all types of medicine? So Schedule 2 through 5, or only some other things? Varies a lot from state to state. It's really like the boundaries of the profession. And it is mostly talked about in terms of health. That's where I'm interested. But there's actually lots of other things. So Arkansas actually has scope of practice that keep residential painting contractors from competing with commercial painting contractors and vice versa, which is really weird. You're like, wait, what? You know how to paint a house, but then you can't paint a commercial building and vice versa. That's really weird. And not as interesting in my mind as the health thing. But it's designed in some ways to provide a consumer protection angle, right? You don't want some quack to operate on you. You want to keep him from, you like your dentist, but you don't really want him to do brain surgery on you, do you? Right? But there's also very much an entrenched business angle, and it forms a barrier to entry. So people who want to provide good quality health care sometimes are prevented from doing it because of the scope of practice rules, which are a barrier to entry. And I want to give you a little bit because you're like, well, I don't know anything about this, so I got to figure it out. So one, are you allowed to refer patients to a specialist for diagnostic or therapeutic procedures? So you think, hey, this is what I do, this is not primary care, you need to see a specialist of some sort. Are you allowed to actually say, hey, we're going to send you to a specialist? Or do you need to go to see someone else first? Secondly, often there's a collaborative practice agreement. Physicians might have to be involved in some way, shape, or form. And actually, let me take a step back. I think I didn't actually give you exactly what a nurse practitioner is. So some of you are nursing majors. I think you know what nurse practitioners are. But if you're not, nurse practitioners are registered nurses who then went on and went to graduate school. So in the old days, they mostly got master's degrees. Nowadays, they mostly get a doctorate in nursing practice. It sounds really fun, doesn't it? You're like, boy, you know what I do? Take a lot of advanced classes in like pharmacology, chemistry, anatomy, and physiology. That sounds like an easy class, doesn't it? No, actually they're not. Then they do a lot of clinical hours. So they have an advanced degree with lots and lots of clinical hours. Much of what they do, at least at UCA where I am, is learning how to actually practice. So they take hard classes and then they spend a lot of time learning how to practice and actually help patients. In some states, nurse practitioners can work on their own. They don't need collaborative practice from a physician. Other states have a rule that says, well, physicians have to look at you. No. Physicians must be up here, and nurse practitioners, they must be down there somewhere, which we'll get to, because that's not true. Oops, I went the wrong way, didn't I? But often they have to have something where the physician says, it's okay, I've looked at it. And you're like, well, that makes sense, right? Doesn't it? It sounds like good things. And MDs go to school a really long time, and nurse practitioners go to school a long time, but not as long. Here's the thing, though. Collaborative practice, they work together really carefully, and the physician looks over all the hard cases. Actually, what it mostly means is that once a quarter, the physician, who charges the nurse practitioner quite a bit of money, pulls 10 charts at random. And of course, if you know any stats, you're like, oh, I bet they're the most common thing. So 10 charts for sinus infection, and then looks at it really quickly and says, yep, that's where I got paid for. So collaborative practice agreement is not designed to help patients. It's designed to sort of be a barrier to entry. And of course, there's also prescriptive authority. Are you allowed to prescribe medicine for your patients? So Florida, they don't have any prescriptive authority. Some states allow nurse practitioners to prescribe Schedule 2 through 5, and Arkansas allows Schedule 3 through 5, under the idea that perhaps nurse practitioners might be tempted to overprescribe opioids, and that we need to keep careful of that. Arkansas does have an opioid problem. It's a serious problem for us. Prescription drugs are a serious problem for us, but those drugs were not prescribed by nurse practitioners. Oh, did we go the wrong way? I'm sorry. So, those of you who are econ majors have seen this graph before. If you're a nursing major, you might be like, what is this? Boy, they're weird people. Scope of practice is designed in many ways, not so much for the patient. It's designed to reduce the supply of healthcare providers, to make it harder for people to see a primary care provider. When they're reducing the supply, then the price goes up, and the quantity goes down. That's how supply and demand works. And you think, but Mitch, we don't have enough providers as it is. Why would we do that? That's a really weird thing. But I want you to look at that price going up. That's an important part. People who are interested in this are very interested in those prices going up. Oops, no, I'm having a hard time today. So these barriers to entry, they lead to things. They're real things, real outcomes. They lead to additional waiting, higher costs, less innovation, more consolidation. And even if you're not an econ major, you're probably thinking, well, more consolidation, Mitch. That sounds like they've had more monopoly power and could raise prices even more. Yes, that is correct.
You click.
Did I hit the clicker again? Boy, I'm having a hard time today. That means less access to care. Also, all of these rules have lots of administrative burden. So it means you fill out lots of paperwork for the state, for all these other things. And what do we want primary care providers to do? We do not want them filling out paperwork. We want them taking care of patients. Especially if you live in a state where there's not a lot of primary care providers, and you don't have an excess number of them, the last thing you want your primary care provider doing is screwing around with paperwork. You want them helping people, right? That's why you hope they became primary care providers, is that every hour they spend looking at paperwork is an hour they didn't help you with some patient. That's what we want them to do. We want them to help patients. This is not my day for the clicker. Okay. Why does it matter? We want patients to have access to care. We want them to be able to see their primary care provider. We want them to be able to get things taken care of before they go really wrong. That's what primary care is. It's that first visit where you take care of things before they become really serious. That visit where you take care of your type 2 diabetes, you get it under control instead of having your foot amputated. I know, it's really cold in North Carolina, North Dakota. You're thinking, maybe I should get my foot amputated. No, that's not what you're thinking at all. No. You want to get these things taken care of. And the great thing is that if you have good primary care, these things get taken care of. And your primary care provider will say, let's get your A1C level taken care of, and they'll work with you, and they'll give you a little kick in the pants about changing some behavior, and you'll get it taken care of. More consumer choices lead to more innovation. So I understand that there's a 7-day retail clinic in the southern part of the city where you can go and just walk in. Is that right? Do you guys have a walk-in clinic? You do? Mm-hmm. Do you know that places that don't have nurse practitioners never got that innovation? That was an innovation done by nurse practitioners. Nurse practitioners are the ones who figured that out. More nurse practitioners means more innovation. Because my physician, who I like, I have a physician. I said it sounds horrible, right? I go to the physician, I talk about nurse practitioners being great. Well, he's not open on weekends. And if you're sick during flu season or during sinus infection season, he'll be happy to see you, maybe next week or the week after. It's actually not that helpful to me. When I'm sick, I'd like to see a clinician. Wouldn't I like to see a clinician right now when I'm sick? Not 2 weeks from now? Yeah. Let's go back to this price thing. There are lots of studies about price and quantity of nurse practitioners. And the thing that's interesting is that even looking at the prices that physicians charge is affected by how much competition they have with nurse practitioners. So it's not just that nurse practitioners are cheaper, and I know that you're thinking, well, I have a copay that doesn't affect it. That's a whole different story. Your copay not being affected by whether you go to an inexpensive provider or not is a different story. But physicians end up lowering their prices of a child visit. So that's just a simple, quick visit. Double check on how you're doing. This is true for lots of other visits. So 15-minute visit by an established patient or a 15-minute visit by a new patient, these prices come down when you have more nurse practitioners. They bring prices down. Hey, aren't we the country that spends more on health than anyone else for not very good results? Wouldn't it be good to have more of this? These people provide good service for less money and better access? I get confused. And of course, rural areas, I actually have so many citations for this that I didn't know what to do because I have 10 pages of citations for this, so I just gave the bold headline. Rural areas have more shortages than anyone else. It's exacerbated by scope of practice regulations and also by reimbursement. So if you're not in health, if you're an econ major, reimbursement, that's just how they get paid. If for some reason you didn't believe me that there's a shortage in rural areas, now you can kind of look at the map and see that there's a shortage. Different groups have different maps, but all of the maps show that rural areas struggle with finding primary care providers. Okay. Well, do nurse practitioners actually serve these people? Or are they just out to get the richy riches, right? That's what you're thinking, isn't it? You were thinking, Mitch, do they even serve these underserved people? They do. There's actually lots of evidence that they do. Including in the Annals of Family Medicine, which is a journal put out by physicians, not by nurse practitioners. So you might say, Mitch, I don't believe this journal is American Academy of Nurse Practitioners. But Annals of Family Medicine, that's a physician journal. And the Federal Trade Commission is a group of people who are mostly economists. So nurse practitioners found that, physicians found that, economists found that. Maybe you should believe it. Now is the question. You're thinking, Mitch, I understand the scope of practice rules can be bad for competition, that they can make it hard for people to see a primary care provider, but some of you don't believe that nurse practitioners provide good primary care. Some of you don't believe that. I don't know why. The results are consistent with a 6-month finding with a growing body of evidence that the quality of primary care delivered by nurse practitioners is equivalent to that of physicians. That's medical care. Physicians' additional training has not been shown to result in measurable differences from that of nurse practitioners in the quality of basic primary care. Hey, I've heard of the New England Journal of Medicine. I don't know a lot about health journals, but I know that one. That's a good one. Oh, that's also a journal run by physicians, just in case you thought I was giving you bad results. No significant differences were found in patients' health status, nurse practitioners versus physicians at 6 months. Oh, JAMA, I've heard of that one. These are top journals. There are a few differences in primary care provided by APN, so nurse practitioners are sometimes called advanced practice nurses, and physicians. For some measures, APN care was superior. While studies are needed to assess longer-term outcomes, these data suggest that APN workforce is well-positioned to provide safe and effective primary care. Well, let's do, I know what you're thinking. You're thinking, Mitch, these are probably some kind of weird statistical test. I want a randomized control trial. Hey, we have a randomized control trial. I like this article right here. Whoops. It's a randomized control trial in JAMA that finds primary care outcomes in patients treated by nurse practitioners or physicians was the same. So again, why do these barriers matter? Why does the scope of practice matter? It matters because it makes it harder to provide quality care to patients. It's costly to set up these collaborative practice agreements. They cost several $1,000s a month for the nurses, for the nurse practitioners. This is a way for physicians to make a little extra money. The other thing is, it makes it less likely that people are going to become nurse practitioners. Why would you give up being a registered nurse to go to grad school for a while, pay tuition, take hard classes to become a nurse practitioner if you're not going to make more money? Why would you do that? The other thing is, it's not just the external motivation. So when economists are talking about external motivation, we're talking about things like how much money did you make, right? That's what we care about. And if you take econ, sometimes it feels like that's all we care about. All we care about is how much money did you make. But that's not the only one, right? That's not the only type of motivation we have. Often people have motivation that's internal. They want to feel good about themselves. They want to feel like they're doing something important. Why would you go and get a doctorate in nursing practice when you're not going to be able to help your patients better, right? People who go and do that, yes, they know what the salaries are. We're not going to pretend that they don't know what the salaries are. They know what the salaries are. But they also think, and I'm going to be able to help my patients, right? Most of us, when we do something, we want to think, yes, I'm making a nice salary, and I'm doing something important, right? Is there anyone here who's like, I'm making something totally unimportant? I think it's ridiculous. Hopefully not, because if you are, you're going to be a miserable person when you get out. Hopefully you found a job that, a major that leads to a job that pays well, so you can pay your bills. I don't want you to be on welfare. But also that you feel like is important. I feel like my job's important. I get to teach people economics. And I get to learn more about statistics all the time, so it's like a double win for me. Okay. Just in case you still didn't believe me that they provide good medical care. No differences were found in patient outcomes. Hey, that's diabetes educator. Family practices employing NPs perform better than those with physicians only. Wow. And those employing PAs, especially with regard to diabetes process measures. Annals of Family Medicine. That's another journal by physicians. Conclusions from this paper. Family practices employing NPs. Oh, is this the same paper? No. No, this is the same paper. I'm sorry. Compared with conventional care, a nurse-led hypertension clinic is more effective intervention for patients. Type 2 diabetes and uncontrolled hypertension. Diabetes care. So, good all-around primary care, good diabetes care. One more thing is, it turns out that actually having a usual source of care is really important. So this is why that access to care is important. That not only do you have a primary care provider that you can get to, but that you have a primary care that you can get to all the time, that you get to know him or her. I don't care if it's a male or female, I don't care if you want a physician or a nurse practitioner, but that you can get to them and that you can get to them on a regular basis, you have the same person. That actually leads to better outcomes. You guys are all young, so you're thinking, well, I mean, you never go to the doctor, right? Last time you went to the doctor was you had to get shots so that you could come to North Dakota State, right? They require that you have measles, mumps, rubella, meningitis. I don't know what other shots they made you get, but they made you get some shots. That's probably the only time you've been. Evidence shows that the quality of care provided by APRNs in retail clinics is similar to that provided in physicians' offices and urgent care centers, and slightly superior to that of emergency departments. Emergency departments actually are not designed for primary care. You shouldn't go to the emergency department for primary care. Again, Annals of Internal Medicine. Boy, all these things. Here's where we have a problem. Someone in the room is thinking, I know a story about a nurse practitioner, and it didn't work out that well. That's an anecdote. That's not data. I also know a story about a physician who had a problem. That's a story. That's not data. This is the same thing that the vaccines had. So there's these stories, you've seen them, like someone's kid got a vaccine, and then it turned out their kid also had autism, and they thought that meant that vaccines caused autism. No, that was one person happened to have autism and also got a vaccine. That's anecdote. That's not data. Please, for the love of God, that's not data. That's an anecdote. That's why I like to look at data, real studies that analyze lots of people, and even the randomized control study. The other thing that sometimes happens when I talk to people about nurse practitioners is they start dreaming. They dream big dreams, which is good. You should dream big dreams. I like dreaming big dreams. If your dreams aren't big enough to scare you, they're not big enough. But these dreams are things like, well, maybe we could have so many physicians that we would never need nurse practitioners. I think your dream kind of boring dream, to be honest. But in the real world, we have a shortage of physicians. There's not enough to go around. And we have this alternative that lowers prices and is good at primary care and is good at seeing underserved patients, underserved populations. So we should let NPs practice to the extent of their training. And let physicians focus on other things. I'm not anti-physician. I still want physicians to do what they do. And sometimes physicians groups sort of lead you to believe that if only we had one more program for rural physicians, then suddenly we'd be okay. I like those dreams, but that's a silly dream. Okay. If you actually believe that physicians are better at primary care than nurse practitioners, then one, you weren't paying attention. But two, you should keep in mind that safety isn't free. Safety is not free. More and more safety is not free. I have an idea. It's a great idea. It's an idea to protect children, so I think you guys are going to all love it. All daycares will have one pediatrician per student. Right? That's not a great idea. Right? We'll have every child will have their own personal pediatrician that follows them around at all times. Well, that sounds like a really expensive thing. What's the benefit? How many lives would we save if we had every child has their own pediatrician? My guess is probably 0. This is a horrible idea. But you can imagine it, and you can think, oh, okay, well, we'll do that. But that means that we didn't do something else. We didn't do something else that might have saved more children, right? That's what we're trying to do. What's the best way to save as many people as possible, to help as many people as possible? We're not trying to sell you like one little thing. We want to help lots of people. If that's not what we're doing, I don't know why we're interested in this. If too much scope of practice regulation is bad, well, why do we have it? The econ majors probably have a good idea. The nursing majors might know. But you didn't get to take econ, I'm sorry. Taking pharmacology. When you could be taking economics. So one is that it's rent seeking, and the picture you have there is Gordon Tullock. Gordon Tullock's one of my old professors, and he came up with this idea of rent seeking that often, and he did it in a very formal way, that's why he's famous for it. You have a monopoly profit, and of course you're worried that other people are going to come in and compete with you and lower the prices that you're getting and take away your profit. Well, what should you do? You should go to your government and say, my God, we have a problem here. People are competing away my profits, and we need a regulation to stop them. That's called rent seeking. And you think, well, how could that possibly be? How could it possibly be that a few physicians who feel nervous about nurse practitioners are able to, outvote all these consumers who benefit? And by the way, not all physicians care. Some physicians who are general practitioners care because they feel like they're losing out on a competition. Cardiologists, oncologists, radiologists, they don't care because they don't compete with nurse practitioners. They don't have to worry about someone else coming in and having a lower price. Well, the way that works is that each of you could be a little bit better off if we had better scope of practice rules, by $1 or $2. But what about the special interest? How much better off are they if they get the rule they want? They're better off by a lot. This is one of the cases where it's actually better to be the small group. We actually get the tyranny of the minority because it's worth it for them. It's worth it for them to get together and argue and say, hey, we need protection. But it's not worth it for you because you're thinking, well, yeah, it's $1, but it's a stamp, it's 32 cents. And then I have to, not watch, whatever I'm watching, not look at cat videos on the internet, and not get troll war on the internet. But for the people who are going to benefit, that small group, that $1 to every one of you is going to only a few of them. And that's why you can have these concentrated benefits at diffused cost. You guys pay the diffused cost, everyone pays just a little bit extra, but one group gets a real benefit. The other thing is, of course, is a capture theory of regulation. And that is this idea that who do the regulators know best? Who do the people who do these rules know best? Well, they know the groups that they get to see every day. That, buy them lunch periodically. And say hello, have a little notebook that keeps track of how old their kids are, what their wife's name is. All these other little things. And then you don't want to be the person who says, well, I can't give you the regulation, even though we've gone out to lunch and you've been really nice and you always ask me about my kids. And then finally, the other way is that, for the most part, most people are rationally ignorant. Why are you rationally ignorant? Well, rationally ignorant means that you're ignorant of some political process, and the reason is because the expected benefit to you of learning about it isn't that high. What did Congress vote on today? Do you guys know? Yeah, me neither, actually. Why don't we know? Just because we don't care, we're apolitical, or we're too dumb? No, why don't we know? Because what's the chance that we could really do something about it? Right? Did you guys watch your congressman today and find out how he voted? Who is your congressman? Yeah. Oh, you know. Who is your congressman?
Like the state one or like local?
Let's go with your state first. You're in U.S. Congress. Okay. So do you know your local one?
Yeah.
This is really, are you poli-sci? Okay.
But I want to go.
Okay, but you're knowledgeable. The rest of us are like, oh yeah, I was gonna do that, and learn about that and follow the thing we voted on today.
No.
Like,
Okay.
I've been following one bill, like, pretty close.
Well, you and I are going to talk later. But most of us, we don't know, and the reason we don't know is because if we did know, what could we do about it? And so we think, should I study for my exam, or should I learn about politics? Studying for your exam leads to you getting a better grade. Learning about politics often means that you can't do much about it. That's really frustrating. That's really frustrating. We talked about concentrated benefits in this first class. So, I'm not saying that we should never license medical professionals. That's not what I'm saying. So what we need to do is we need to have some kind of balance. And we need to keep in mind that licensing boards, licensing groups have a tendency to want to protect their own and not have any competition. But we do want them, right? It's actually hard for regular people who didn't take any of these courses to know, like, is my physician over prescribing? Do I have a quack? That stuff would be really hard to know. I know that there's some problems with licensing boards too. So if some of you are thinking, I know of a guy that shouldn't have his license, I know those stories too. And finally, what we really want to think about when we're trying to balance these ideas, we're trying to balance the idea of we want to protect people, but we don't want to protect special interests. We want to make sure that we are thinking hard about outcomes. And when we talk about nurse practitioners and we talk about physicians, people often want to talk about inputs. Well, physicians have this many hours of study in medical school and this many hours of study in residency. Well, I don't care about how hard you worked. I care about how well you do, right? You go to your professor and say, I know I got a 30 on the exam, but I worked really, really hard. Your professor doesn't really care, does he? What your professor cares about is that you figured out what the class was about. You notice that he kept talking about this one issue again and again and again. You're like, he's going to ask that question. And you had good outcomes, right? We care more about outcomes than we do about inputs. And we especially care about it for health, where we want people to be healthy, not people to go to school, right? So if we could actually have primary care providers just do, they put the little computer thing on their head. It's like in the movies, and suddenly they know how to be, instead of saying, I know Kung Fu, they would know primary care. That would be fine. I don't care how you learned it. I want you to be able to provide good primary care. Okay. Yeah, we're still going to do licensing. We're still going to license pilots. We're still going to license physicians. For some reason, the physician's license didn't come about. We talked about that, I'm sorry. The other thing is that, what if patients just prefer nurse practitioners? Nurse practitioners might have better bedside manner. I actually have a physician who has a very good bedside manner, but maybe for you, nurse practitioner has a better bedside manner. On average, nurse practitioners spend more time with patients in office visits. On average, physicians spend 7 minutes, and nurse practitioners spend 12 and a half. You might think, hey Mitch, that sounds like almost twice as much. That's right, that is almost twice as much. NPs have a tendency to focus on holistic preventative medicine. They spend a lot of time doing things like talking about diet and smoking cessation. Why would we want to prevent a patient from picking a provider like that? That sounds like a good provider. Why would you want to prevent someone from going to the person who spends a little more time with you and talks to you about the fact that, hey, maybe you should lose some weight, and please quit telling yourself that you're not a smoker because you only smoke 1 cigarette a day. You're a smoker. And smokers have 12 times as much cardiac problems as non-smokers. Here's the other thing, is that sometimes people do this over-licensing, and it means that now you can't get a provider. We've over-licensed so much that now you can't get a provider. Well, what does that mean? Does that mean that you did your own work? Does that mean that you went to some weird quack that you saw in the back of the newspaper? We don't want you to do that. So oddly, if you go to YouTube, you should not follow this. But if you go to YouTube, there's all these videos of people like doing self-surgery. That's a horrible idea. Don't do that. Or they're like, oh, my friend did it. No. We want you to see a real person, a real provider. And we want them to have incentive to compete on quality and be good. And we want to also remember that it's not scope of practice that makes nurse practitioners good. It's that they have good training. And what would happen if you went to the nurse practitioner and he or she wasn't very good? Same thing that happened if you went to the barber and they weren't very good. You'd never go back again. Does that sound like a good business model? Hey, I got a great idea. I'm going to see people once and never again. Not for most industries. Well, this is the one that I'm sorry. This is supposed to be what about the children? But we can't get the animation to work. But there's a tendency when people are talking about nurse practitioners to say, well, what about the children? What if the end of the world comes about? This is designed to get you to look over here. Don't look at this data over here. Look over here at this other thing that's not data. It's sort of scare tactic. This is really awkward for me. You guys are doing great. Normally when I give this talk, I have to tell people, you should really change your rules. But North Dakota has the right rules in scope of practice. You guys let your nurse practitioners practice to the full extent of their education. And you've been doing it for a really long time. So it's kind of weird because normally if I'm going to tell people they're doing a horrible job, now I've flown up to North Dakota, and you guys are doing a great job. And you've been doing a great job for a long time. South Dakota just changed theirs, by the way. They just changed the governor decided last week. But you guys are doing great. I don't know, I can't see color, but whatever color that is with North Dakota, that's the color you guys are. That's a good one. I'm sorry, I'm colorblind. You guys are doing a phenomenal job. I know that you still have access to care problems, you still have primary care shortages. The dilemma is that nurse practitioners are great, but they aren't magicians. So just having good scope of practice regulation doesn't mean that everyone gets their own primary care provider or their own individual one. But it is good. You guys have done what you could do. You've done the things that are actually possible to do. And I wish that my state would do the same thing, because we have a serious issue in Arkansas where people don't have primary care providers, especially if you're poor and you're on Medicaid. So there's a county that only has 2 primary care providers. Neither one accepts Medicaid. I don't know what those people are supposed to do. What are they supposed to do when they get sick? Not be sick. That's what they're supposed to do. I'm not really sure how you're supposed to do that. So yeah, you guys have done a great, oh, gracious. But anyway, thank you very much. I appreciate your time. And I'd love to answer all of your questions.
Yeah.
And you and I will talk later, because I'm excited that you actually know who people are, you know what bills are going on.
So we do have plenty of time, but if
I'm sorry,
anybody
I got
has a
excited.
question that they would like to ask, feel free.